Well, thank you all for being on this hot Friday afternoon. We got lots of cool things happening, and we've got some new folks on our call today. So really, I just wanted to um, level set and say that this is a statewide stakeholder meeting for CoCM. And Dr. Gibson actually started this stakeholder meeting maybe 2 or 3 years ago. She said, there's a lot happening around CoCM across the country, and it might be a great idea if we had some focus here in Arkansas so we could hear from people what they're doing, what their needs are, what their questions are. And so then we got the CoCM grant, and we said, wow, okay, now that we've got the CoCM grant, this is a really great landing place to continue to bring anyone interested in CoCM, anyone that has questions, suggestions, things that they've been doing, things that they're trying to do that haven't been working, to the meeting. And, I think we have a broad range of people who attend. We have individual organizations, we have providers, we have payers, we have people working in the policy space. So lots of different people who are all here for the same purpose of advancing CoCM. So that makes me excited because we've all heard it takes a village. Well, for CoCM, it really does take a village to get this implemented and to get this paid for and to get the outcomes that we want, because there's a lot happening in the space. So thank you all for being here today. We've got our new clinics on. We are in the process of onboarding River Valley Medical Wellness to the SAMHSA CoCM project, and we also have McGee Family Clinic who will be onboarded to this project. So really excited about that. And I'm smiling because I'm looking over. I didn't forget anyone, did I, Caitlin? Okay.
No, that's me multitasking. I'm sorry, the eyebrows are not
No worries.
listening.
Like, did I get one of
Oh,
them wrong?
sorry.
So a couple of things that I just want to remind everyone. If you know of someone who is interested in CoCM, but maybe they have some specific questions, we do monthly office hours on CoCM once a month, and that is a statewide meeting that really is a drop-in, just drop in if you have questions. So anyone on your team or anyone that you might have friends, you might have people in other clinics that are like, hey, I want to know more about CoCM. Tell them to join us. We are always there and always eager to help folks. A couple things. We will be going down to do some training. We'll be going down to train River Valley on August 13th. Then we'll be training McGee on August 14th, and we'll be bringing the Woven Docs in, and they will be joining us. We're going to have a road trip across Arkansas, so we're really excited. We're going to hit the central and southern parts. But in addition to that, I wanted to let you all know, I don't know if this project will be affected and or incorporated in any way, but ABIN has received a PCORI grant. And so we're really excited. Yeah, we received a PCORI a community engagement grant, and the purpose of that particular grant is very separate. However, it might have an opportunity to affect this in some way. The purpose of that grant is strengthening the voice of the peer in behavioral health integration for comparative effectiveness research in Arkansas. So we're really excited. It's a small, it was an award for small organizations. And so typically it's not the type of award that we would be eligible for, but we're really excited because ABIN as an organization, our mission is really to further and advance the behavioral health integration in the voice of the health consumer or peer. So we will be looking at that, and I will keep you all posted. But we're just in the beginning phase of that and really just getting started. But we want to just let you all know that's one of the things that are happening. And I think it's important because on this meeting, we've talked a lot about CoCM, and we're trying to find articles to talk about cost effectiveness, and we're trying to talk about outcomes, and we're trying to talk about policy pieces and convincing payers and reimbursement rates, and how could this fit into a value-based payment model. So all of these pieces are happening, but it's really challenging to get a lot of traction. So I'm hoping this type of project could bring some additional credibility to the work we're doing for NEED. So please know that that is happening. And then I feel like I'm talking a lot, so I am going to pause for a minute because we want to. I love our new members. They're going to talk to you a little bit about their clinic and what their goals are for CoCM. And so I would love our new folks to go first. They could introduce themselves. They can talk a little bit about their clinic and their goals and purpose. And so I know Dr. Martin has limited time, so I don't know if River Valley wants to go first. We've got Tucker Martin up here in my first Hollywood Square. He could introduce himself, and then Dr. Martin, and talk a little bit about River Valley and what you all are doing.
Absolutely. Thank you, Kim. My name is Tucker Martin. I serve as Chief Operating Officer for River Valley Medical Wellness. We are owned and operated. We're a privately held organization. Kristen Martin, who is on right now, is our CEO and founder. She and I are not related. We just very coincidentally share a last name. And Dr. Martin is currently at Conway Regional. We've got some folks out of Florida, Gulf Coast ultrasound in training our entire medical team on doing CE training for ultrasounds. That's part of a maternal health grant that we have that is another little carve out of the state opioid response grant. So Dr. Martin, I don't know if you want to take a break and say hello. We've got a PowerPoint. I'm happy to talk you guys through that.
I was trying to figure out the presenter view. I'm doing
just like that. It's just fine. It's fine.
Are you sure?
Yes, ma'am.
Misty, I think if you go to slideshow, slideshow on there you go, and then go to
there we go.
Yeah.
Ooh, well, this is a first. Thank you, Kim.
You're welcome. Misty thinks I don't have any technology skills.
Not true. Not true. Dr. Martin, take it away.
And Doc, if you want to just say hello, I can talk us through the presentation.
Yeah, that's fine. So I'm Dr. Kristen Martin. I appreciate
us finally being able to join us. And I say finally, I appreciate so much ABN and Dr. Gibson and people we've been talking to over time, interested in the CoCM model, and that we finally get the wonderful opportunity as an organization to participate in this and be able to learn and initiate this in our clinic. So I apologize that I can't really stay today. So we're doing our ultrasound training. Our whole medical team is here, but I am grateful, and I'll let Tucker do the slideshow. And if anybody has any questions or anything, I can answer later. Is that okay?
Absolutely. Thank you for being here.
That wasn't very informative. Hi.
Hi, thank you for all your excitement and energy around this project.
Thank you.
Well, we're River Valley Medical Wellness. Our main clinic, our original clinic, is in Russellville, and we have run a clinic in Hot Springs for a couple of years now. An ever-growing staff, currently about 30 team members, and expanding and growing. Next slide. So Dr. Martin had a dream of providing integrated healthcare services, particularly in rural communities. And I'll just tell you a brief version of the origin. As an emergency department physician, she's got deep roots in Russellville. She ran the ED at St. Mary's for about 9 years and left when the hospital sold, and kind of went into the Baptist ecosystem. So during the pandemic, along with everybody else in the healthcare profession, she was working every single day. She was deployed to Baptist, mostly Baptist emergency departments in Arkadelphia, Stuttgart, Malvern, Heber Springs, Dardanelle, Danville, and she recognized something really important in the early days of the pandemic. We were thankfully had really low case numbers, new case numbers early in those months. But what she was seeing in an emergency department, and again, she had been working in EDs for 12 or 15 years at that point. But there was an influx of misdiagnosed or undiagnosed behavioral health concerns, and real serious influx of untreated and undiagnosed substance use disorder concerns. She tells this story all the time. She was rightfully, along with everyone else, very proud of that idea of being a frontline worker. But for certain scenarios, especially when it comes to behavioral health and substance use disorder concerns, she quickly realized that the front line is not the emergency department. That's our last line of defense. So she wanted to get into the space and open up clinics in rural communities, provide integrated healthcare services so we could address primary care needs, mental health care needs, and addiction care needs in a manner that is reflective of how patients experience them. And they're intrinsically connected with one another, especially for substance use disorder. It's undeniable that in almost every single case, there's some kind of typically unaddressed or unrecognized behavioral health concerns that fuels our substance use disorder patterns. I know that. I'm 9.5 years sober myself, so I have that type of experience. Next slide. So the primary care aspect of what we do is exactly, it's listed here. It's exactly what you would expect. That's how our clinics feel. If you just, all of our front-facing, patient-facing stuff, there's nothing really unique or unusual. It's a friendly, welcoming environment. And patients can engage with us at any level they want, take advantage of any of the different, essentially, service lines that we offer. Next slide. Mental health care, behavioral health services is the fastest growing component of what we do at River Valley Medical Wellness. And it encompasses everything from screening, assessment, diagnosis of virtually every behavioral health condition that you could imagine. We inch really close up to SMIs, right? That's outside of our scope. Got great outbound referral partners when we need to increase level of care. We do a lot of group therapy, individual therapy. That's an important component of what we do. We do it in a way that's non-judgmental. It's very accessible, very approachable, and easy to engage in. On the psych side of all of that, medication management is an important component of what we do. We talk about new patient acquisition. We hear it all the time when people come to us. They've sought services maybe at other facilities and get told that the waiting list for a new patient appointment is in excess typically of 6 months. We keep growing our staff to be able to accommodate a shorter wait time, and we devote specific time in our provider schedules to be able to accommodate new patient appointments. Next slide. The addiction care program is a crucial component of what we do. I'm one of many people in long-term recovery that are a part of the River Valley Medical Wellness family. Most of our people in recovery are peer recovery support workers. If you're not familiar with that, those are people with lived experience in active addiction who have attained at least 2 years of continuous sobriety, and they go through a program through the state DHS, and they're trained, certified, and credentialed by DHS in partnership with NADAC, and it's tiered very similar to if you were going to be a licensed drug and alcohol counselor. So you become a peer in training, accrue hours test, you can become a certified peer worker and advance up the ladder. Those are vital team members. That lived experience that they share with people in our care is important. Medication assisted treatment is a significant part of what our addiction medicine program looks like. For opioid use disorder, that's going to be buprenorphine. Alcohol use disorder, typically naltrexone. Unfortunately, there's no approved medication-assisted treatment for stimulant use disorder, but there are some comfort medications that we can prescribe based on an individual's needs. We're happy that the pharmaceutical industry has kind of caught up with substance use disorder needs. We've had long-acting injectables in behavioral health space for a long time, and that is starting to filter in. Long-acting injectables are certainly a preference of patients and providers. There's literally no chance for diversion in that kind of scenario. So we deploy that when it's appropriate for a patient. Oftentimes payer concerns might restrict access to some of that. The state has been really good right out of the gate. Vivitrol's been on formulary for state Medicaid for a long time. The state legislature acted very quickly recently and made Brixadi, which is a long-acting injectable form of buprenorphine, got that on formulary. So hopefully the rest of the private pay insurance world will catch up and recognize the benefits of those medications. Next slide. It's a patient-centered approach, everything that we do. Our kind of internal model is to find practical solutions for the often complicated and complex medical and behavioral health needs that our patients face. And what we were just talking about with medications, we can prescribe anything, right? But if it's an impractical solution that in and of itself creates a barrier for the patient, we want to be cognizant of that and make appropriate decisions that our patients can really engage in. Next slide. And compassionate care is always our driving force. We're grateful to be able to partner with the state. A lot of money comes from the federal government through SAMHSA. So we participate in the state opioid response grant that gives us MOUD services for people who are non-insured or underinsured. We also have a wonderful relationship with the American Indian Center of Arkansas to provide MOUD services for uninsured individuals. That includes um, medical appointments. We'll pop back to that other slide if you don't mind. Oh, yeah, sorry. You're on the right one. I apologize. Um, Therapy and a variety of other services. Peer services are always included in those. We have a grant through the state, again, another carve out for SOAR that helps us provide some services to at-risk youth and young people who may struggle with some behavioral health concerns, certainly substance use disorder use, use patterns, and misuse patterns among our young people are significant. So we're working in a variety of areas in partnership with DYS and AJAC, the youth treatment facility down in Benton. And that's a growing part of our business. And we, part of what Dr. Martin is doing with our medical team right now, we're participating in a maternal health grant. As you all know, we have the poorest ranking in the country when it comes to fetal and maternal health. The governor and the legislature have directed a variety of resources and funds to improve our ranking. So being able to provide ultrasound services in rural environments, especially to at-risk mothers who may struggle with substance use and misuse, we're grateful to be able to participate in that. Next slide. Oh, yeah, there's one more thing. Next. Mobile healthcare. That's a huge part of what we do. Quite some time ago, we launched our nonprofit division called Arkansas Mobile Opioid Recovery. You can go to the next slide. So those are two mobile health clinics, and you can see on the screen, these are full-size Class A motorhomes, about 42 feet long, but it's not the kind of RV that you're going to go tailgate at a Razorback game or go camping in. They're purpose built from the chassis up to be a medical and clinic. So they've got two fully stocked, fully functional exam rooms, a patient waiting area. We do a lot of addiction care. So we have a laboratory with pass-through for urine drug screens, a little nurse's station, and a laboratory. As you would imagine, in our environment, we draw a lot of blood and process a lot of UDSs. So we've miniaturized basically every service that we offer in our brick and mortar clinics, put it on wheels, and we take it out into rural communities. And if you'll go to the next slide, I'll show you what the growing footprint of that is. We really want to extend that reach into rural communities outside of kind of our home bases, which are Russellville and Hot Springs. We're proud of each one of these deployments, and those are growing. And those are really intentional partnerships with stakeholders in each of those communities. We're not trying to come in and take over any medical care from anybody that's been providing services in any of our deployment locations, but they've all recognized the value of partnering with Armor and adding a layer of specialized care to make it more accessible for the patients that they serve. Next slide. So I apologize if that was lengthy, but that is our mission and our focus. There's our phone number, rvmwellness.com, if you want to learn more.
That was fantastic, Tucker. Thank you. You know, one of my takeaways was you all saying the behavioral health component is one of the fastest growing pieces of patients' needs. And so CoCM will help your clinic be well positioned to meet those, behavioral health needs. We'll be able to identify individuals, track them through a registry to see, are we seeing improvement? And if not, they'll be able to get real-time psychiatric consultation. And hopefully we can get folks feeling better and meet the needs of that rural population. So I'm really excited. That was a big takeaway for me. Anyone else have questions about River Valley and the work they're doing?
Honestly, I'm surprised with all that you guys do and everywhere Dr. Martin's at. I'm surprised you got it fit in the time amount that you did. So that was awesome.
People are usually not that shy. I'm joking.
Well,
Sometimes.
we are really, really excited to finally be a part of this process. This is something that we've been working towards for quite some time. Thank each and every one of you for welcoming us, and we're eager to learn what you're doing and piggyback off some of the great work. I'm sure we have a lot of good interactions to come.
Oh, absolutely. We've got experienced partners. UAMS has been doing this the whole time, and Tish is on, and they've got 5 clinics onboarded in East Arkansas. They've got their clinic up and running, and so cool things are happening. All right. If we don't have questions, we can turn it over to the McGee team. And if you all don't mind introducing yourselves and then telling us a little bit about your clinic and the work you do.
Well, I sure can. And wow, Tucker, that was just, it was very impressive. That is really something. Y'all are doing some wonderful work. And someday we may be like at that level. But we are not nowhere near that. In fact, we are really scratching the surface here in Southeast Arkansas. When you say Southeast Arkansas, usually that's a precursor for lack of resources. And it has been. We have really been just very fortunate to have partnered with Mel Rita Johnson's The Chosen One Professional Services for behavioral health and the services she provides for us. We started with a grant. Oh gosh, what was it? 3 years ago? 3 years ago. Wow. 3 years ago, to begin looking at some of the social, that's when social determinants of health was becoming, that's when we learned that term. And she really helped us identify a lot of those through a grant, working through our clinic, identify the social determinants of health for us in our clinic. And then we have gone on to renew those grants for some of that, and do some others, have some other ties with her work through some of our inpatient and hospital, our hospital side, to work with some of our case management and discharge planning. So her group is really even making a difference on our inpatient discharge side too. We have, even before let me back up just a little bit. I'll try to be a little bit impressive. We didn't have anything like that plan. So I'm glad you took a little time, because it gave me a chance to pull up a couple of things to share with you, so we weren't completely devoid of anything, so of any kind of presentation. This is our hold on, that's not where I wanted to go. What I did want to show you is
Did you want to share slides? Oh, okay. You got it.
yeah, this is our website. It's not really much, but we our McGee Family Clinic is a part of McGee Hospital. We're a very small critical access hospital. Really, and I usually we have an emergency room that is terrific serving our patients. We do observations. We do inpatients. Our inpatients are really restricted to those things that our primary care physicians take care of. We have 3 of those really that take care of their own patients. It's real old school looking, as well as our nurse practitioners that work primarily in our clinics. So we have, there's that guy. There's that handsome guy. There you go. One of the things I did want to share with you too here is that we just completed our community health needs assessment. In fact, we just did our board presentation Tuesday for that. I want you to see, this is part of one of the pages that we have. looking at some of the perspectives, and the community health needs assessment, if you're not familiar with it, is a review of every 3 years. It's required by Medicare that every hospital is required to do to assess needs in their communities that their community feels are important. So in our community, as you can see, got kind of color coded here, but alcohol substance use was a big one. Diabetes, cancer, obesity, heart disease, and mental health. You know, it looks like our top three were really diabetes, obesity. That can almost go together right there. That's almost one and the same. And we've got heart disease here. We got cancer. But if you look, alcohol and substance use, mental health issues, many times, of course, we know tied together. I'm just an administrator. I've been doing this a long time. At least I know those are tied together many times. So 2 out of the 6 indicators that we have that our community is identifying that they see, this is what we want you to work on over the next 3 years. 2 out of 6 of them have to do with things that we can affect through behavioral health integration initiatives. So I really found that to be very profound for our community. Just that it's not only are we seeing that from our side, but our community is recognizing that as well.
Absolutely. I just wanted to say, wow, when you show that visual, that really speaks to the need, right? The need for this type of program. I mean, it's hopefully we can see changes. Let me ask, is this on your website, the community assessment? Will we be able to find that later?
I was just looking. It's supposed to be our 2022 one is on there. So
Okay.
it's not been uploaded. I think I forgot to send it to. Thank you for reminding me. I think I forgot to send it to our website manager. So I need to send that to him so he can upload that. But yes, it will be on there. It will be on there next week. So.
Oh, no worries. Yeah.
So if you want to see that, those are really interesting, and every hospital is required to post those, so you can get some really good. And I bet you behavioral and substance is coming up for everybody, as we know. So we do we have our clinic consists of we have one independent physician that works nearby. Our clinic that we have it consists of 2 physicians and 2 nurse practitioners. So real small environment, but we have 11,000 patients, or 11,000 visits a year. In our chronic care management, we carry about 400 patients. We are changing our EMR, and I think that's really going to enhance both of those things, especially our chronic care. And that is, of course, chronic care management is where we identify a lot of those things that we are really going to be integrating with behavioral health integration for us. The key for us is really implementing a behavioral health integration program into our primary care practice. At present, we don't have that. I didn't make that clear. We don't have that presently. So this is step one for us, and we are just really happy to make it. Obviously, our community sees it. And our providers certainly see it. So it's just something that we're glad we can start making some progress. And I will be quiet and let Melrita talk about real important things like what we did identify, and then other important clinical stuff. I'm just the man that keeps all the paychecks going.
So I'm Melrita Johnson. I'm a licensed certified social worker, and one thing that our CEO didn't tell you was that we have an amazing CEO who has he's humble, and he's minimizing really what all McGee has done prior to even trying to bring in social services. So I'm going to highlight what he just piggyback off of what you heard the 11,000 number, you heard the 400 and something, you heard that we've never had mental health. They have tried to manage that with just his medical team. And they have managed it with just their medical team until he allowed us to come in and try to help him. And so that speaks volumes to an area where if you're familiar with the HIPSA score, we're 19 out of 26 in Deshae County, which is very, very high in everything. Okay. So that's another thing. So we serve from youth all the way up to elderly. We've seen anything from a minor crisis to a big crisis to crisis with placement issues, substance abuse, inpatient, uh, inpatient, intensive outpatient. So we're seeing the whole gamut. And so now we're able with this grant to be able to really, we've already started engaging the community, because in an area like that is very limited on what we can do. But now we have you all's help to be able to kind of spread out. You know, we work closely with Exodus.life when it comes to substance abuse. Now, Jessica at the Delta Counseling, we've had to become BFFs with her. She's the director of the emergency services. So when she answers the phone, she's like, "Hey, Mary." So we work really, really close in how do we work together, because we're not on separate islands. And that's what you usually kind of see with small rural places. They all kind of just do their own little thing and nobody really kind of communicates. And so the other thing that we're looking at is developing a task force down there. So with the task force, we've had homeless, we've had prison dropping patients off in the hospital, having to sit there and babysit for the weekend. We've had people stab people 28 times and have mental health issues and think that the hospital is going to babysit these people when that's not what the staff is should be doing for safety reasons and just protocol reasons and even just for care reasons. And so we've had to navigate and learn, and all the way up to, I'm calling Mr. Terry, "Can I call the governor?" And he's like, "Calm down, Milford." Because those are the things that, you know, in rural areas, I think sometimes our voice it's not heard as loudly as in bigger areas like, say, a Conway or a Little Rock or a place like that. So we're looking at bringing together the mayors of the cities of the Deshae County, the mayors, the sheriff, the police officers, the clinics, the emergency response, fire trucks, the emergency ambulance, everybody, because the jails, because we don't even have a jail to even be able to house people, and we have to use other people in the area to even house someone. And so, and we're working, we don't just work Monday through Friday. We don't do bankers hours. Everybody shake your head and say, "Yeah, we know." We don't do bankers hours. This is Monday through Sunday. This is 12 in the morning to 12 in the morning. Like, this is all the time, because we never know when a crisis is going to happen. So we're anxiously awaiting to be able to really we've done some work. We've threaded the field just a little bit. So now with you all behind us, I can't wait to see what this really, really looks like, and us to be able to be at Dr. Martin and Dr. Martin's level and higher, to be able to serve our clients down in McGee and in Deshae County.
Awesome. Wow. So what I'm hearing is lots of amazing work happening really in a rural area where you haven't had a lot of resources, but you've come together and you are leveraging all the different resources in your community to maximize how you could help your patients in your community, which is truly, truly amazing. Yeah, Michael.
And Kim, I was just going to say how impressive it is with Terry and Melrita, their absolute dedication to the people that they serve there in McGee, and the innovativeness of Dr. Martin and Tucker Martin. Oh, they're having a hard time going to the doctor. That's fine. We'll just put together a medical assault vehicle and we'll come see them. Mm-hmm. I mean, how awesome is that? And Melrita she kind of just blazed over it. But I've been around enough rural medical facilities where the attitude is, well, it's not anybody else's job, it's my job. And we're here to take care of people. And it's not that it's not anywhere else, don't get me wrong, but it is so prevalent in some of these rural facilities, especially rural hospitals and rural clinics. We're all busy and we all do a lot, but after having Tucker and Terry and Mel Rita on this call, I feel lazy. I feel like they walk in juggling with two different balls, four different balls, two different hands, and balancing a plate. And she's got two phones, probably is on her iPad and her computer as well. And Tucker is over there probably closing two other contracts for two new locations. I mean, I am just so impressed with everything that they do, but also how well they do it, but really just the passion, Kim. It's just awesome. So,
well, one thing, Dr. Keck, sometimes it's not a matter of choice taking care of some of the patients, but we do, and we do the best with it we can, and we make a good situation for their families as well. And Melrita's being a little humble herself. I mean, you can count the number of social workers in South Arkansas on one hand and probably have four fingers left, because it's really, so she has provided some folks down here, does a lot on telehealth, so that helps us out a great deal.
Absolutely. I was just going to say, I know Teresa's not on our call with us today, but we're talking a lot about implementation science and the important pieces. And so for us, one of the critical components for the project that we have is we have champions. We have identified champions at each of these clinics to kick us off. And so that's an essential piece for this model that we know is essential. So I have to say thank you for your dedication and thank you for your willingness, because we know with your support, that's one of the absolute key pieces to make this project successful. So we're going to do cool things, and my hope is in 2 years when we're sitting here, we're going to be like, wow, okay, now that we've got this up and running, we have to talk about how to refine things. We can say, one of our pain points now with East Arkansas is their BHCM is a full caseload, and they're saying, okay, now that I have a full caseload, it's starting to become too challenging to balance all of the people. So let's talk a little bit about that. And so my guess is we'll be seeing that in 2 years when we're here at this meeting talking about those pieces. Okay, I'm watching the clock because I know we have limited time. So any questions for McGee? And if not, I don't think we have David Jones on. So Misty, did you see? Am I missed? No, okay. Just want to make sure. Sometimes I can't see everything when I'm facilitating. We'll table any updates or information from the state, and we'll ask Tisha if she wants to give us a update on all the awesome work she's doing with UAMS.
Hello. Thank you, Kim. It was so great to hear the stories. You guys are doing some great work. Really excited to kind of be on this project with you, and I'm always willing and excited and want to be a resource in any way that I can. So if you have questions about what we're doing and how things are working and talk about troubleshoot things, I'm happy to do that. I can talk about stuff like this all day long. So my name is Tisha Dean. I'm a clinical psychologist by training. I am the Director of Behavioral Health Integration for the UAMS Primary Care and Population Health Service line, which is a fancy title I gave myself when they hired me, which basically just means that I really just help to support, bolster, and implement evidence-based practices for integration in all of our primary care clinics. So at UAMS, we have 16 primary care clinics located all over the state. So we have clinics in Jonesboro, Batesville, Helena, Pine Bluff, Texarkana, Fort Smith, Fayetteville, Springdale, El Dorado. Those are our regional programs. And then centrally, we have 2 clinics here on campus at UAMS. We have one in West Little Rock at Rawling Road. We have one over in downtown Little Rock at the Capitol. We have a longevity clinic here in actually in the building I'm in right now, which only works with people 65 and older. We have a house calls clinic where we do home-based primary care. And I think that's all of them. Yes. So, one of the things that we have done is we've had integrated care as far as what's normally called kind of the primary care behavioral health model. We've had embedded licensed clinical social workers and licensed counselors that kind of work to do embedded care, and we've been adding collaborative care as part of this project. We had started that a little bit before the project, and this project has really helped us to kind of move things along. So we're right now in 5 of our clinics at UAMS with collaborative care and the PCBH. So it's exciting. Some of the challenges we have is that we have just so many, and every clinic is its own little entity. So when we try to implement in each clinic, it has its own exciting adventures. And also we are a residency clinic. So so 11 of the 16 clinics have residency programs, which means that we have first year, second year, third year residents. So every year we have a new group of residents that are getting onboarded, and they all have their own things that they're learning. So, on top of the medical care and the great care that our physicians provide, they're also teachers and preceptors, and our team is also involved in teaching, precepting, and didactics and all of that part of the clinic. So on top of kind of the clinical workflows, we get to kind of try to work around and work through and be teachers too. Which is really exciting because then we teach many, if not almost all, the primary care doctors in the state. And so one of the things that I am really excited about is once we get all of this implemented is that most of the doctors who are trained in the state of Arkansas will have had experience with and been trained in areas in clinics that have these structures, and they're aware of how to use them and can be champions across the state. So that's something that excites me about doing this. I wanted to share just real quickly our caseload tracker. I feel like that once you kind of get a case, it's kind of exciting to look at. And so for people who are starting on, it might be interesting to see. Let's see if this will do it. And I really just am going to take a high level. But so we use the Ames caseload tracker. East Arkansas also uses the Ames caseload tracker. We're trying to build it into our EHR, but that is a challenge that's happened across the state. But we right now have 96 people enrolled across 5 clinics. We have had challenges in getting people up and rolling. So it's definitely not the numbers we want, but it's the numbers we have right now. And this caseload tracker really helps us. I've got it sorted by status. So we're new in most of our clinics. So most of our clinics started fall last year or early 2025. So we're still early on. And so we've only got 4 people right now in response prevention. So, most of our people are still new. And you can see that, if I sort by our PHQ-9s, we have a lot of people who have pretty high PHQ-9s. So you say mild to moderate, we have some pretty severe levels. And it was a pretty high G87s too. So, we have people who have, pretty severe levels of symptoms. And that's one of the challenges we've had is that you build something new, the most acute is going to start. This the patient you're going to get first, and so that means that we have a lot of work to do, and so we have kind of lower caseloads that we want, but we're pretty busy with this crew. The other thing I wanted to point out, and it may be the same for you clinics, is that we have an incredibly high level of PTSD symptoms. So we have patients, we have an 80, which is an incredibly high PCL score. Most of our people you will see have significant trauma. We don't treat trauma in our collaborative care, but we do a lot of education, and we try to prescribe medicines around trauma, try to help with anxiety and sleep and things like that. And we try to get people set up with trauma treatment, but we all know in the state that that's a commodity that's difficult to get to. But I think that it's just important to acknowledge and to be thinking about and preparing for. So I will stop sharing. Maybe. There's the button. So there's a lot of things we could talk about, but I know we don't have a lot of time, and so that's just a little mini update. And again, I'm really excited to work with all of you. And I'm a native Arkansan. I grew up in Northeast Arkansas. I went to school in Fayetteville. Whenever I hear about the work that you guys do, that warms my heart, because those are my communities and the people that I love too. So I'm really excited to hear about what everybody does.
Awesome. Thank you, Tisha, and thank you for sharing that registry. It's great to see how we're identifying patients, how we're tracking patients, whether patients are getting better, not getting better. One of the things, and I am watching the clock, so I'm not going to get off on a tangent, but I think we've come so far in other fields of medicine and looking at having tests. And then we can give clear interventions and see improvements. But we haven't really done a great job in the behavioral health field. And so I think for us, an opportunity to start using tracking measures is something that is going to be very helpful, which is one reason I like the CoCM model. I know Caitlin has prepared some announcements. And so before I hand it over to you, Caitlin, I just wanted to say the Arkansas Academy of Family Physicians is having their conference on Friday, August 15th. And so we will be doing a CoCM presentation there. AFMC has organized a panel, and so they'll be talking about some of the billing components, and then they've asked Dr. Gibson to speak to this, I think from the payer lens, and then I'll be helping talk through some of the workforce pieces. So that's happening August 15th. If you all are interested, please attend. And with that, I'm going to turn it over to Caitlin to talk about some of the announcements.
I don't have anything big, and I know we're just at about time. So, Sarah, do you mind sharing about that VHCM meeting? I had the privilege of attending a new cohort that the Meadows Institute has organized, and I was just going to ask Sarah if she could share about it, because she'll probably be more factual than I am.
Happy to. Hey, everyone. I'm Sarah Burns. I'm the Vice President for Health System Implementation at the Meadows Mental Health Policy Institute. Meadows is based in Texas. I'm based in Phoenix, but I've had the privilege of attending these Arkansas-based meetings for at least the last year or so to really kind of keep an eye on what's happening in all the different states and share resources across. Part of our work at the Meadows Institute right now is working with the National Council for Mental Wellbeing as the training and TA provider for the PITBIT grantees, of which, as you know, Arkansas is one. So as part of that work, we're starting 2 new groups. The first one is for behavioral health care managers from anywhere in the country with a focus on the SAMHSA grantee states. to come together, kind of share resources, learn from one another, troubleshoot, et cetera. So that's what Caitlin was able to attend. And we are also starting another group similar for psychiatric consultants, kind of talk about the unique issues that those folks encounter, get support, and kind of learn how to be more effective in that role as a consultant. Right now, neither of those groups have a presence on our website. They're that new. So I'm going to put an email address in the chat. If anyone's interested, just send an email, say, hey, I'm from Arkansas. I want more info about the group for BHCMs or for psychiatric consultants. Happy to send it. And then once we have registration or an info thing or something like that, that's more on an enduring web link, I'm happy to share that as well.
Thank you so much, Sarah. I really appreciate it. And like I said, she's gonna put that in the chat, but we'll make sure we can send it in a follow-up email as well. And Terry, Tucker, and Marita, those are things that we're also gonna make sure that your BHCMs know about as well. So we'll follow up on that too, and just provide every opportunity we can just to support each other at a national level as well. The only other actual CoCM or like integrated resource that I have that's coming up is, of course, the CFHA conference in October in Raleigh. We will be presenting there with East Arkansas on the implementation that we've been able to do with them so far in this program. So we're very excited. We will be there. We'd love to see you there as well. And then two more things, unless I'm forgetting something. We did just have our AVEN webinar yesterday morning, and that Jen is usually pretty fast with it, so it may already be on our website. But we had a really good response to a creative approach to recovery and using smartphones and apps for that. So if you're interested in the subject, that should be on our website or at least our YouTube to listen to that. We've had really, in my opinion, really good ones for the last couple of months in a row. But coming up, Kim and I are actually going to be doing in August for our webinar on the 14th from 8 to 9. We'll be doing an adolescent expert training that is available for one CEU that you're welcome to come to. If you haven't registered for our monthly reminders, feel free to email me or Misty. We can put you on that list as well. And then I don't want to forget, Tisha shared last month about the Arkansas Psychological Association conference. I wasn't sure, Tisha, if you had a link for registration yet.
Not yet, but save the date, October 9th and 10th, that the focus is going to be on suicide support and prevention, and also like recovery for family members. And there's going to be a really neat community space, or like a day where it's mostly focused on the community, and then there's a day that's mostly focused on clinicians. It's going to be really, really great. So mark your calendars, October 9th and 10th.
And then thank you, Tisha. I always ask Michael, I know you mentioned that there was another educational opportunity coming from UAMS, and I can't remember the date.
Yes, it's October 2nd. It's our Women's Mental Health Forum, and you will soon be receiving information. I was hoping to already have it to share by today, but we had a little curve thrown at us the other day. So we're finalizing the agenda, and we'll have everything within the next week or so.
Perfect. And as always, let us know how we can support getting that word out. October is clearly very busy for learning opportunities. So the dates sound like we can all make it to each one, but we'll see. And hopefully see you guys there. But if there are any other upcoming educational opportunities that you guys want us to send out that is before we meet again in August, just email me or Misty. We can get that out too. And that's all I had, Kim.
Awesome. Thank you. And we are working on website updates. So hopefully in the next couple of months, we'll be able to give another demonstration of the beautiful CoCM website. With that, I hope you have a wonderful month, and we will see you in August. Take care.